Welcome back to the second part of John's case, and I'm going to first start with quite an important technical point, which is that obviously in this case where the margin of error was virtually zero, we decided to use a surgical guide. Now there are different types of surgical guides. Let me show you the type of guide that we used in this particular case. The surgical guide that we used in this particular case has got advantages and disadvantages. I decided to use this particular type of guide because from the outset I only needed the surgical guide purely for the positioning of pilot holes. The rest I was going to do freehand in a technique that I will describe to you in a few minutes. The one thing that is important with surgical guides is that you test them in the patient's mouth prior to surgery. And this is what precisely happened in this case. So even though these surgical guides are supposed to be precision fitting, when I tried it in the patient's mouth, there were 2 or 3 places that didn't allow it to seat properly. This is paramount to a surgical guide. You need to be able to seat the surgical guide precisely and have windows where you can check that the contact points are in position at the outset of treatment and also whilst you're drilling your pilot holes. If there is even a slight discrepancy, and especially in this kind of case, it can lead to catastrophic consequences. From the outset, when I tried this surgical guide in this patient's mouth, there was 1 or 2 little catches. We adjusted those and we were able to fit it properly prior to starting surgery. This is a lot more complicated when you're in the middle of surgery trying to correct a surgical guide. You've got acrylic, and acrylic and open surgical sites don't mix too well. So I place all my patients onto 5 things prior to surgery. I wanted, and I will put the description, the detailed description in the link below. The first thing is that we give the patients amoxicillin starting 1 day pre-op and for 4 days post-op. For pain management, we give the patients ibuprofen, paracetamol with codeine. I want the patients to use warm salt water for the first 3 days post-surgery, then to move on to chlorhexidine digluconate mouthwash. I also ask our patients to take an anxiolytic, one tablet the evening prior to surgery, and a second tablet 1 hour pre-op. Finally, we always recommend that our patients take probiotics with their antibiotics. Now let's dive into the case. So John was anesthetized with 2% lidocaine with adrenaline, a buccal and a palatal infiltration, just like we always do. I raised a 3-sided full thickness flap and I ran an incision line starting quite high up, just between the 1-2 and the 1-3, distal to the papilla, distal to this papilla because we don't want to affect the aesthetics. And then we did the same thing on the left-hand side of the patient's mouth, just distal to the papilla in the 2 site. The palatal incision was run on the palatal aspect, not on the crest, but on the palatal aspect of the mouth. This gives me full access while protecting all the surrounding tissues. On the palatal aspect, we made an incision along these gingival margins. I ran the incision across here and then up and around these margins. And then we raised a full thickness flap, and I will show you what that looks like. A full thickness flap was raised, and we can see that we lifted it all the way apically so that you've got a full view of your surgical site, especially during the surgery, so that you have complete control and observational access both on the buccal and on the palatal aspect. And here's where the technique gets interesting. We place the surgical guide in position, and the first thing that is important to note is that this surgical guide is sitting properly. And there are a few observational windows. The first was in this area. That was your second point of contact. The third, we made sure that there was no gap distal to this area. These surgical sites were carefully chosen from the implant planning that we previously showed, and they were for the exclusive use in this particular case only for pilot holes. I immediately assessed that the bone quality in this area was very soft, so we purposely underprepared because of the soft bone. Slow rotational speeds, copious irrigation, and we placed primary pilot holes in the 1-1 and in the 2-1 sites. It is important to note that on these specific drills that there is a stopper at the end of the pilot hole, and it is important that you drill until the stopper engages onto the surgical guide, and once you do that, you know that you've reached your optimal depth. These collars are positioned in precisely the right place in order to give you the correct length of pilot hole. And this is what the 2-1 site looked like, with the pilot hole exactly hitting the collar so that we know that we've reached the full length of the pilot hole. I will prepare a separate lecture on bone spreaders. So once we'd prepared the pilot hole, we used the Nentwig bone spreader, and I will talk to you at a separate lecture about that, but it's a really useful, highly recommended tool taught to me by Professor Nentwig. And we used the bone spreader to widen the pilot hole, and then we carefully placed an Ostem US3 SA 3.5 by 11.5 millimeter implant immediately into position, and this implant torqued at 40 Newton centimeter, nice and solid, and that kind of thing allows me to smile broadly. The 2-1 had narrower bone coronally, so we flattened and trimmed the coronal aspect of the ridge. We used a 2 millimeter pilot drill first, and then we expanded this site gently with a Nentwig bone spreader or osteotome to a 3 millimeter diameter before placing the 3.5 by 10 millimeter implant, and this torqued down to 25 Newton centimeter, and I was delighted with that kind of outcome with this quality of bone. We placed healing caps over the 2 implants, and finally we sutured with 2 interrupted 4-0 polysorb sutures. Hemostasis was perfect, and John's partial denture was fitted again to replace the 1-1 and the 2-1 sites immediately. Aesthetics matter even on the day of surgery. In the 2-2 and in the 1-2 site, I placed sutures that went around the teeth to give us stability of the tissues in this area. This is the front view of the wound closure and sutures. And after surgery, John went home with clear instructions for his pain management, oral hygiene and follow-up. We took a post-op OPG to confirm the implant placement and scheduled him to return in 3 months for the second stage procedures. I was delighted with the post-op OPG, but over and above that, I took a periapical because I wanted to be very sure about the implant positioning. And we can see from the periapical that the implants were in an ideal position, and there was more than enough bone between the implant and the adjacent teeth, and also between the actual implants. The patient was informed to return in 3 months for a second stage procedures, basically to check the osseointegration and to prepare the crowns. So the key takeaways from John's particular case are, number one, that preparation is everything, especially with these aesthetic cases. Precision matters, so even when you prepare your pilot holes, if you're unsure, take a periapical and make sure that you are going exactly in the correct direction in a 3D perspective, because it allows you to correct if you're not. Soft tissue and aesthetics are paramount, especially in the front of the mouth. And finally, gentle bone handling If you feel the quality of the bone and it is too soft, drill carefully, drill slowly, and rather use osteotomes, because it will give you the kind of quality of bone that you desire to place the implants. It doesn't make sense to be drilling away to the optimal diameter in soft bone, because you're then still left with soft bone. Remember that bone is gold dust. And finally, plan for hiccups. Check to make sure that the surgical guide fits properly. Have backups if your primary plan doesn't unfold as you desire or plan. And that's a wrap for John's surgical case. We'll move on to part 3, which is the prosthetic stage.